In this video, we're going to talk about problem lists and problem representations. Now, this is a way that we're going to use to organize the information that we get from patients. We get information from our patients by gathering a history as well as a physical. And then we have to take it and organize that information and construct it into a way that we can use to compare it to the illness scripts that we have created for the various diagnoses that we are considering in this patient. And we may have an illness script table of various diagnoses we're considering in this patient. We want to be able to compare our patient to those diagnoses in the illness script table. So here is our framework for clinical reasoning that we came up with before. And again, there's the 4 steps that we go over many times: acquiring data, interpreting and organizing data, making hypotheses, and then testing those hypotheses. In this one, we are going to focus on this portion right here, interpreting and organizing information specifically from a patient. All right, so let's take a look here. So here we have a case. We have a patient who comes in saying that they're having trouble breathing. So that's our initial data that we have. And so we got some data. We interpret this to mean that we think that they're short of breath, and we start making some hypotheses. And that's what this big list over here is, a differential diagnosis of many things that could cause shortness of breath. Now that list is huge, and we don't have enough information to say that it is or isn't any of them. So we need to get some more data first before we can start narrowing down that list. So the next step that we would go to is getting information from the patient through the history and the physical. And so let's talk about that. And so when we take a history and physical, we do it in a very structured way. And these are the different components of it. We have the chief complaint, which is the reason why the patient is here. It's usually in their own words, and it's usually a few words or a sentence that explains to us why they came to see us today. The history of the present illness is their description, a subjective description of today's illness, of what is going wrong with them. There's structure to that too, which you're going to learn in your history taking class. The review of systems lets you ask questions about all the other body parts that maybe have nothing to do with what is going on today, but you just want to double check that we're not missing anything. Past histories asks them what past medical problems they have, what other conditions they have, what surgeries they have, what allergies they have, what medications they have, because that can be important information as well. Now, the physical exam is the objective part of data gathering, is where we collect the information ourselves by observing the patient. And finally, we get testing. So that's a result of blood work and x-rays and procedures and various other things like that. And so together we get all that data. And so here is what our patient gave to us. Now, it's a lot, all right? And so we need to organize this somehow so that we can make some sense of it. I'm not going to read all of this here. You can pause the video. And so when we organize it, the one way that we can organize it is by making a problem list. So that is to go through this information and figure out all the things that are abnormal. And so that's what I've done here. I've underlined and made yellow all the things that are abnormal. It's not abnormal to be a 42-year-old woman, but that may be something that's important. But the rest is abnormal. Now we can collect all that information into a problem list. And here's all of that information collected together. Now we have to process this list, because even this list is a lot of information that by itself doesn't get us anywhere. One way we can process the list is by using something called semantic qualifiers. Here we got that. And these are paired opposites, terms that usually mean one thing or the other. And this medical terminology you are going to learn throughout your career. And so don't worry about trying to cram all this in now. We're going to pepper this through your entire education so that you can start picking up some of this information. But let me give you some examples. Acute versus chronic. Acute means that something is happened now in the short term, and chronic means something that's been going on for a long time. So a pain can be sharp or it could be dull. It could be bilateral, meaning on both sides, or just on one side. It could be constant or intermittent, mild or severe. It can happen at rest or with activity. Okay, so if we were going to take some examples here, so you could take something that might have been on your problem list, like chest pain, and put it into more detail using semantic qualifiers. So that might become acute onset, severe, crushing, chest pain at rest. Shortness of breath might be chronic shortness of breath with exertion. Headache could be acute onset, severe, frontal, that means on the front part of the head, the forehead, headache. And so this sort of information now allows us to take that big problem list and compact it down some. So let's take a look. So here's our problem list that we had before, and we're going to use some semantic qualifiers and medical terminology. So trouble breathing becomes dyspnea. Started 2 days ago becomes acute onset. Developed a cold, viral symptoms. Stressed out at work, social stressors. Worse when climbing stairs, exertional. The heart rate of 110, well, that's fast. We call that tachycardia. Blood pressure 140/80, that is high, so we call that hypertensive. A respiratory rate of 24 is fast. We call that tachypnea. And wheezing on one side, on the right side, unilateral bronchospasm, or you could say unilateral wheeze. And finally, crackles at the bottom of the lung, unilateral basilar rales. So you're going to pick up these terms as we go forward. But I just want you to see that we've taken things that are in maybe lay terms and put them in the medical terminology, because that's how our illness scripts are going to be populated with this medical terminology as well. So, speaking of illness scripts, we talked about that in a previous video where we took information from books and we stored it in an illness script and included these components. And that's for a disease. We can do the same thing, sort of, for a patient. We can take the information that they gave us, right, from the chief complaint, history of present illness, review of systems, past histories, physical exam, and various tests, and store it in an illness script for a patient. And it has very similar components. Epidemiology here is in both, time courses in both, signs and symptoms in both, diagnostics in both. So you can see the similarity there. So let's take this problem list now that we processed using semantic qualifiers and put it into an illness script for a patient. So our epidemiology would be, this is a 42-year-old woman with a past history of asthma and depression, right? We want to know, epidemiology is the who of this, right? So the who is our patient, this is our patient. The time course, it's acute onset. We know it was 2 days. Symptoms and signs, viral symptoms, social stressors, hypertension, tachypnea, tachycardia, etc. We don't have any diagnostics yet, and here are the other past medical histories if we should need them, right? And now we can put this into what we call a problem representation, which is a short paragraph encapsulating what we found. So we took that big thing of information that our patient gave us before, and now we've condensed it to this. A 42-year-old female with a history of asthma and depression presents with acute onset of exertional dyspnea associated with subjective fever. She has had some social stressors. She is hypertensive, tachycardic, and tachypneic with unilateral wheezing and crackles on exam. And so this now is our problem representation. See, we don't ever really call it an illness script for a patient. We call it a problem representation. But I thought that was a good model to use since we've already talked about illness scripts. Okay, so now we have a problem representation. Now, this is our illness script table that we talked about before, right? And we have 3 diagnoses in here that can present with shortness of breath. And here is our problem representation, or our patient's illness script in here as well. We don't have something for pathophysiology for a patient. And now, like we did before, where we looked for key features, differentiating features, we can do that here too. So exertion, right? Something that gets worse with exertion. So our patient has this, and it's present in all 3 of these diagnoses. So that's a non-differentiating feature. What about crackles? Crackle is only present in 2 of the 3. So that's a differentiating feature. You don't tend to see that in asthma, but you can in heart failure and pneumonia. The crackles are a sound you get in the lungs when you listen with your stethoscope. Kind of sounds like kind of like that. Next is a key feature of fever. Of these 3 diagnoses, fever only appears in our pneumonia illness script, right? And what about a rejecting feature? Must have an anxious mood, right, for a panic attack. And our patient did not have an anxious mood and did not look panicky either. So we have a rejecting feature for panic attack. So now let's look at that. I've circled all the things we have in here. Which one do we think our patient has? Which one is most likely? Well, pneumonia has the most things circled here, the most features that are similar to what our patient has. So we might think this is probably our most likely diagnosis. Heart failure is still possible. There's a few of them here, and asthma has less. So if we were to rank order these, we might say pneumonia is our first most likely, second most likely, and third most likely. Well, we can at this point now get some imaging. Why don't we get a chest x-ray? And you can see an image of a chest x-ray here. And this is our patient, and you can see here this fluffiness here. That is an infiltrate consistent with an infection, and we do not see over here any pulmonary congestion consistent with fluid buildup. So now let's look at our x-rays. So chest x-ray must show infection, may show infection I should say. Chest x-ray may show fluid, and we usually don't need a chest x-ray for mild asthma here. So now we have even more information saying in the pneumonia column, so that becomes even more likely. So how sure are we that this is pneumonia? This is a bit of a gut feel here for right now. We'll figure out how to more accurately pick numbers, but let's say we feel very likely or likely. Let's say maybe 89% or 85%. We're going to put it in this columns here. And in heart failure, asthma, and panic attack, we're going to say are less likely. And this is the probability that that patient has that disease, right? So pneumonia is very high up there. And remember, our goal is to categorize it into one of three different categories: the treat it, test it, or trash it category. Treat it means that we have enough information to confirm the disease, that we've ruled it in. Trash it means that we have enough information to rule it out, that we are not going to consider that disease anymore. And test it means we need to collect more information. Ultimately, we want to push all the other diagnoses into the trash it zone, and our one into this one, into the treat it zone. So I think we have enough information in our patient to say that they do have pneumonia, and so we're going to treat it. And so we're going to give them some antibiotics to help them get better, and have them follow up with their doctor to make sure that things are improving with them. All right, and so that we looked at right now is problem lists and problem statements. And it's a way of organizing the information that you get from your patient. First, you're going to take all that information that they give you in a very structured way, and you're going to pick out all the things that are abnormal. You're going to take that list, that problem list, process it using semantic qualifiers, and try to organize it in such a way using a patient's illness script. And from that, you can put that into a few sentences, what we call the problem statement or problem representation. And then you can compare that to various illness scripts for disease. All right, that was this video. I want to thank you for watching, and I will talk to you later.